Hello.
Sunil, good morning.
Sir. Good morning, sir. ಕೇಳಿಸ್ತಾ ಇದೆಯಾ ಸರ್?
I spoke to ರವಿಶಂಕರ್.
ಸರ್.
ಹೇಳ್ದೆ ಅಪ್ಪ ನಮ್ದು 2 to 4 ಇತ್ತು. We wanted to postpone it to 4 to 6.
Sir. Request our IAP President Dr. Raghunath sir to give his opening remarks.
Thank you.
Over to you, sir.
Good morning to all. Thank you very much for giving me this opportunity, Dr. Sunil. We welcome all the students on board, and we also expect more people to join shortly. Sir, since it is a Sunday, we have a little problems because
ಸ್ವಲ್ಪ ಲೋಡ್ ಮಾಡಿ.
Okay, what I'll do is I'll log in from my mobile and do it. Okay. Just 2 minutes.
Yeah, sir, you can speak, sir. Volume is little low, that's all.
Good morning, everybody. Well,
yes, sir.
Welcome to.
You are
Sorry,
audible,
it is.
Sir, unmute.
Good morning, everybody. Welcome to the first postgraduate program, which is online. We welcome all the students. Please do take advantage of these sessions. We are bringing in one of the best people in the field of pediatrics
to help you understand pediatrics in a better way, and also to help you write your exams in a better way and be successful. Growth and development is a very important part of pediatrics, without which we cannot survive. So if there is any falter in the growth, we can always look back and see what is the cause, whether it is nutrition, whether it is something else related. These are the things which are very important for a general pediatrician. Sir, our Anurag Bajpai sir is one of the pioneers, endocrinologist, and he has a special interest in developmental pediatrics. He is going to make this subject very simple, and he will also be talking to you about how to chart the growth charts and how to look into and when to intervene. These are the things which he will be telling, so that it becomes easier for you guys to manage, as well as not just students. It is also going to help us all to revise and revisit into the topic. So welcome to Dr. Anurag Bajpai sir. Sir, thank you for being around today and sparing your valuable time for our students as well as our faculties here. So we welcome you, and we also welcome Dr. Nagbhushan sir and Dr. Subbarao sir in absentia, because he is already a panelist. I mean, he's a speaker in another conference, so he is not able to be here. Dr. Subbarao sir and Dr. Nagbhushan sir's brainchild is this, and we would like to welcome Nagbhushan sir here, and also our Sunil, who is our secretary, who is putting the hard work behind all these things, and Purnima, who is Dr. Purnima is an endocrinologist, and she has taken up the vote today to be with us, and Dr. Rajendra Salgiri is our EB member, who is also actively participating and who would be the anchor for today. So over to Dr. Sunil. I would request Sunil to hand over the mic to Nagbhushan sir for a brief summary.
Thank you, sir. Thank you very much, sir. Now I request Dr. Nagbhushan sir to give his opening remarks.
Very good morning. I will not stand between you and the speaker, but a few words. We have been doing the PG teaching program of IAP Bengaluru branch from the past 20 years. What was the program focusing on? Clinical pediatrics bedside approach. But somewhere we felt that the students also needed a little bit of pepping up of the theoretical aspects, particularly the difficult to understand topics which needed an expert to make difficulties very simple. So we have had about 10 topics which we have chosen based on the last 5-6 years question papers, both from DNB and MD questions. And the PGs would be aware if I share with you that the last 5 years questions on growth and development have already been shared with Dr. Anurag Bajpai, and he has singled out 2 questions which we had sent him, which that does not really fall into the realm of growth and developmental assessment. So a good homework has been done for the PGs. Now, we had no questions in our mind that who should address us regarding this topic. And I'm so glad to share with you that Dr. Anurag Bajpai has very gladly accepted our invitation and responsibility. He has some pressing family commitments. So without wasting much time and welcoming Dr. Anurag again, hoping that he will join us in many activities in future. The dais is yours, sir.
Thanks a lot, sir, for this wonderful invite.
One second, sir. I would request Dr. Rajendra, sir, to introduce Dr. Bajpai, sir.
Good morning to respected chairperson, secretary, and convener and co-convener of this online CME. And I'm very happy to be a part of such a novel program wherein we are having online teaching sessions. So as we know, growth and development forms the essential part of history taking, examination, and even analyzing any pediatric patients. Because growth and development, not only it analyzes wherein we can analyze the patient at that point of time, but with with monitoring, examination of growth and development, we can predict the future problems, anticipate the future problems in that child. So to discuss this vital subject today, and we are privileged to have Dr. Anurag Bajpai, sir. He is a distinguished pediatric and adolescent endocrinologist with a training from AIMS. He has done MD and he has international credential, including FRACP, that is Fellow Royal College of Physicians, and SCE from UK. He is currently president of ISP, that is Indian Society of Pediatric and Adolescent, and having been served secretary and treasurer in the past. His vast clinical experience and academic expertise make him exceptionally well suited for today's online session. So I now invite Dr. Anurag Bajpai, sir, to kindly take over the session.
Thanks a lot, Professor Nagbhushan, for this wonderful invite and providing me this opportunity to interact with this important forum on this topic. I'd also like to express my thanks to the entire IAP Bengaluru team, Dr. Raghunath, Dr. Rajen, Dr. Purnima, for inviting me. And I'm going to focus on overall approach of growth failure, including practical aspects. With towards the end, we'll also see how we can tailor out in terms of the answers of the questions which have been presented to us, which are commonly asked in terms of the examinations. So I think what we'll do now is that we'll start off with this case, which I always start off highlighting why we need to be very cautious in terms of growth evaluation. This was a 17-year-old boy with short stature who was referred to me when I had just come back to India. And unfortunately, like many of the other children who come to us, already the bones were fused. Now, this child had all the features of celiac disease. The child clearly had anemia. There was pallor, there was clubbing, everything was there. So it was written over the face that this is celiac disease. But unfortunately, because of anemia, the earlier treating physician had given him blood transfusion, which had culminated into HIV/AIDS. So a simple scenario which could have been solved by changing the diet had such an adverse outcome. And this was approximately 17, 18 years ago. And this was really unfortunate and shook us up and to do something in terms of awareness. Now, why is this an important issue? Because the burden of pediatric endocrinology, including growth and pubertal disorders, is huge. There are a limited number of pediatric endocrinologists in the country. What we need is to empower pediatricians, physicians, and those with special interest to work in this direction. And that's what we are trying to hope. At least these parts, and as we discussed, that growth is a fundamental part as far as pediatrics is concerned. So with that aim, we started our e-learning portal, which is on YouTube. There are a number of videos available, including many of the talks that I'm talking today would be available on YouTube. You can have a look out there. We also have an online learning portal, MediClasses, learning.growsociety.in, where we have got tailored courses on different aspects, including for postgraduates from that perspective, and that can be quite helpful from that regards. So I'm going to focus about key aspects of growth evaluation, particularly growth chart, puberty, and bone age, as to how clinical assessment can help us reach a particular diagnosis without relying on investigations. And when we do investigations, how to interpret them appropriately. So this starts off with this case, a 12-year-old girl who is referred as evaluation for short stature. Now, what we know from a pediatric endocrinologist perspective is that most patients who even come to us with growth failure do not have a pathology. From a pediatrician's perspective, that is 80%. So 80% of children will not have pathology, but significantly 10% can have a significant pathology, which can have a life-changing effect, like diagnosis of celiac disease. They may have a life-threatening effect, like a brain tumor, like craniopharyngioma. So the role of the pediatrician in evaluating a child with short stature is to not do unnecessary investigation in those 80% while not missing out on those pathological causes. And this is what my whole aim would be about this talk, to base a foundation how clinical clues can help us identify pathology, identify the need for evaluation in that regards. Just a few theoretical words about regulation of growth. We know that genetics accounts for 60 to 80% of growth. So the final height ultimately is determined by genetics. And this switch to genetics happens by 2 years. And remember, this becomes important when we'll talk about a case of cash down growth later on in that regards. So what does mean that whenever we are interpreting growth, we should interpret in terms of target height range. And we'll talk about how mid-parental height is identified and how do we decide about that particular range. Endocrine factors are important, but they are not the major players in terms of pathology. They can cause severe short stature, including growth hormone deficiency, thyroid defect, and cortisol excess. Obviously, there are systemic illnesses. Any abnormality which is happening anywhere in the body is going to influence the growth hormone IGF axis. So malnutrition is going to cause growth hormone resistance. Systemic illnesses and inflammation are also going to reduce the growth hormone action, causing reduced growth. There are also local and paracrine factors which are not very important therapeutically, but may play an important role in the development of skeletal dysplasia. So all these factors are important from that regard. And of course, we have got intrinsic factors like shocks, the defect of which causes growth failure in Turner syndrome from that perspective. So genetics is the key aspect in terms of overall assessment. Just to highlight about the growth regulation, we know that the major regulator is the IGF-1 axis, the growth hormone releasing hormone coming from the hypothalamus, stimulates the growth hormone production, which then acts on the liver on the growth hormone receptor produce IGF-1, which causes skeletal growth acting to the type 1 IGF receptor. So essentially, it is this axis which is primarily causing the linear growth. I'm going to focus predominantly on linear growth today from that regards. Growth hormone also has a local effect. Other hormones play important role in the form of thyroxine, which are very, very important in terms of chondrogenesis. So if you have severe hypothyroidism, the growth plate may actually become damaged from that perspective. There is a very vital role of sex hormones, and we know now that it is the estrogen in both genders produced by local aromatization from testosterone or directly produced in females, which is responsible for epiphyseal growth as well as epiphyseal fusion. That becomes important. And of course, cortisol has a significant impact. So there are a number of factors which play together in that regards. What this suggests that if you are evaluating somebody for the growth hormone axis, you need to have a normal thyroid, a normal cortisol, and a normal pubertal status. So if you are interpreting growth hormone assessment in somebody who has hypothyroidism, Cushing syndrome, or delayed puberty, there may be issues, and this will become relevant when I talk briefly about how do we evaluate for growth hormone axis from that regards. And then, of course, we have the intrinsic factors. Now, a very interesting model was developed a few decades ago by Michel Lamp, which talked about the 3 phases of growth. And it is not entirely substantiated, but it does give us a framework. So we have got the infancy, in which there is a rapid growth. Then there is a continued growth which happens in childhood, followed by another peak growth which happens during puberty. And different factors determine different aspects in that regards. So we know from the ICP model that the maximum growth happens in the fetal period, approximately 50 centimeters. And in this period, the major determinant is the environment. It is the insulin level, the IGF-1 level. It is not affected by growth hormone. So individuals who have growth hormone deficiency or hypothyroidism have a normal size at birth. Infancy is the second most rapid growth phase as far as body is concerned, gaining around 30 to 35 centimeters. Childhood is a phase of slow growth, which is going to track us in that regards. And somebody from the age of 2 years till typically puberty will continue to follow the same track. So if somebody is not following the track and crossing 2 or more percentile lines between the age of 2 years and puberty, that becomes significant. And that is something which we are really getting worried from that regard. And of course, in puberty, we gain a lot. Remember, the potential of height gain is dependent upon the pubertal status. It is not dependent upon the age. So beyond the pubertal age, around 10, 12 years of age, it is the pubertal status, the skeletal maturation, which play a more important role in terms of assessment from that perspective. So as I said, fetal period, it is environment largely. Insulin and IGF-1 becomes important. And we know that in infant or diabetic mother, they can be large because their insulin levels are high. Infancy is largely nutrition. So first 1,000 days, nutrition plays an important role along with thyroxine. Growth hormone and thyroxine play a role in childhood onwards. And of course, in puberty, we have got estrogen, or you can say testosterone, which is converted to estrogen, which play a role in terms of growth. So this model gives us a subtle idea as to which disorder will present to us when. So if you have a nutritional problem, it's going to present to you early. GH will typically present around 2 years and onwards, and CDGP will start presenting around 8 to 10 years of age. So identifying that can help us reach a particular diagnosis. Now, a very important phase of life is, of course, puberty. And what we need to remember is that pubertal spurt in girls starts at breast stage 2, while in boys starts at testicular volume 4. I'll touch base a bit briefly subsequently. The maximum growth happens at stage 4 in girls of around 9 centimeters per year, and testicular volume of 10 ml in boys of around 10 centimeters per year. So other thing to remember is that the maturation happens from proximal, distal, while fusion happens from distal to proximal, and this becomes important from that regards. The usual duration is more. The boys are a bit taller as compared to girls because they have got longer duration to grow. They get extra 2 years to grow, and they grow a slightly faster, and therefore there is a 13 centimeter difference. And when we talk about MPH, we talk about the 13 centimeters being important from that clinical perspective. So now coming back to what we have discussed till now, we have clearly talked about that the major determinant are, of course, genetic, nutritional, and endocrine. So when we talk about growth failure, and this can help you really classify growth failure, when somebody asks you, how do you classify growth failure? You can classify into physiological causes in which the constitutional delay of puberty and growth is there, where everything is delayed. So these children will be short for the population, but they will be normal for the bone age. Familial short stature, in which they will be short for the population, but they will be normal for family. This is like 80% of all population. Then we have pathological causes, in which the problem can be within the growth plate, which is primary. So you can have a small for gestational age child who has an intrinsic reason for growth delay. There may be syndromic disorders, typically Turner syndrome in girls and Russell Silver other in other aspects, or skeletal disorder. Now, these primary disorders are easy to identify. And subsequent to that, we have secondary disorders in which we can have nutritional or endocrine cause. These are quite different clinically. The tests are different. So if you're talking about nutritional cause, you're talking about celiac disease, malabsorption, malnutrition, tuberculosis. The workup is TTG, X-ray, ESR, blood gas in that scenario. While endocrine is hypothyroidism, growth hormone deficiency, pseudohypoparathyroidism, and Cushing, the workup is different. Usually, from a clinical perspective, we can easily identify physiological and primary causes. Then we land up in this regards. The most important thing to differentiate a nutritional from an endocrine cause is actually the weight. The most important thing to look at in a short child is the weight. If somebody is short and lean, that is nutritional. Short and plump, that is endocrine. I'll talk about that. How do we really objectively decide whether this child is short and fat or short and lean from that regards? So 3 questions that a pediatrician has to answer in a child who presents to us with growth failure is it really short stature? Is it physiological or pathological? Is it primary or secondary? Or is it nutritional versus endocrine? So before we really decide whether this child is short, we need to do a proper growth assessment. Now, there are 2 parts of growth assessment. One is a single value. It's like a snapshot, which is the immediate height that you have measured. And the other is the running picture, which tells us about the growth velocity. So both are important. Unfortunately, we often do not have growth data to really look at longitudinal information. So it's very important that every time a child comes to you, you should measure their height. Now, this question is very, very important in India because this is not happening. IAP long back, 18 years ago, came up with guidelines about when should children be managed and measured. So they said at birth, of course, then with every vaccine visit, 6, 10, 14, according to that time schedule, and then 6 monthly measurement becomes important. Couple of things to remember here is that at birth, penile length measurement is absolutely important because if there is micropenis with undescended testis, that can be a sign of missed congenital adrenal hyperplasia and can be lethal. If there is micropenis with descended testis, we are talking about multiple pituitary hormone deficiency. So penile length becomes important. Pubertal assessment becomes important from around 6 years of age to identify early puberty in that regards. So linear growth assessment, we all know, is that we can do it via the length, which is done typically till 2 years of age or till the height is less than 90 centimeters. Remember, when you are stretching the child in infantometer, it tends to be more than 1 centimeter compared to the length. You need 2 observers, place the child in infantometer, keep the head in the Frankfurt plane and measure it appropriately. For height measurement, we've got stadiometer, which is done after 2 years of age, and ideally it should be measured till minimum value of 0.1 centimeters, and in triplicate, remember that in daytime, because in the morning our muscles are in a good tone, our height is a bit more, the spine is more straight. So remember to take it every time of the day. Very importantly, if somebody has contracture of the extremity, we can take the upper arm length as an indicator. And if there is a spinal deformity like kyphoscoliosis, the knee length can be a good marker from that regard. So height measurement, absolutely important. I've not discussed too much in detail about the measurement. What you need to remember is that, of course, they need to be barefoot. They need to have their Frankfurt plane horizontal. They need to have their occiput, the buttocks and the back of the heel touching, and stadiometer is the best way to identify. And this would require a practical demonstration in that regard. Once you have measured and found somebody to be short, the next step, of course, is to look at body proportion, in which you, of course, look at the occipitofrontal circumference, look at the upper segment to lower segment ratio, which is from head to pubic symphysis, that is the upper, and pubic symphysis to the bottom becomes the lower segment. Easy way to identify is a sitting height. You take the height of the child in the sitting position. That gives you a rough idea about upper segment from that regards. And remember, children have much longer trunk, and then gradually their limbs become bigger, and therefore around 7 to 10 years we have got unity in that regards. Arm span is relevant from a tall stature perspective to identify in that regards. Other things which are important, which will be relevant from a skeletal dysplasia perspective, is the rhizomelic index, which is the ratio of the forearm to the arm, which tells you if your distal part of the hands are short or not. Sitting height, which we already discussed. A very, very important component is the assessment of parental height. I've already said that in general, in most population, the male adult height is 13 centimeter higher than the female adult height. So what do? You calculate the mid-parental height, you average both of them, add 6.5 centimeters for boys, subtract 6.5 centimeters for girl, and then this will give you the target height or the parental height. Now, there, of course, will be a range within that, and we will have a target range of approximately 1.5 standard deviation score, which will be around 6 to 8 centimeters. So if a child is lying plus 1.5 or minus 1.5 STS from this target height range, this will be normal, and this is the parental height. I'll show this in a growth chart also to make it more simpler in that regards. Remember that if you have only one parent who is very, very short, that would mean that there may be a possibility of an autosomal dominant disorder, which may happen in that regards. Now coming on to the most important part, the most important investigation or workup in a child with growth failure, that is growth chart. No test, no treatment should be written in anybody who is coming to us with growth failure unless we have really plotted the growth chart and evaluated it appropriately. So growth chart provides us with pictorial depiction. It's easy to plot, easy to interpret and follow up. I remember around 30 years ago, we did not have the growth charts, and what people used to do is to use tables in which they just have to see the tables, and then it becomes very, very difficult. So growth chart clearly is the standard way to go forward. Now, from a theoretical perspective, this may be relevant from examination perspective is what is the difference between a growth standard and a reference. So when we talk about standard, it is how ideally the Homo sapiens should grow, while reference is how exactly we are growing. So standard is in ideal environment circumstances, should be for the same individual whom we are plotting, while reference is just a cross-sectional data. So a standard is ideal, so there should be no disease, there should be ideal nutrition, ideal physical activity. Design, of course, will be longitudinal, and we measure ideal growth, and this will have a higher value, but will be much, much more difficult to identify from that regards. So an ideal growth chart should be recent, less than 10 years, local, should be representative of the population, and should avoid confounders like nutrition, infection, which may cause compromise of growth from that regards. Very importantly, if you have some children who are very tall or very short, you remove them, especially the effect of obesity, and LMS model is a model by which you can smoothen the median standard deviation, other aspects to make it more smooth from that regards. Now, I'll just talk about a few charts. So CDC chart was one which was used a long time, and still the WHO uses it from 5 to 18. It is based upon the American children, NCHS data, unselected middle class children with 7 percentile points. It is a cross-sectional. It's not a reference. It's not a standard. It's a reference from that regards. Now, WHO took a very big study to develop child growth standards, and this was developed in 1,700 children. Now, remember, it's not a large number, but what we're talking about is multiple measurements have been taken in these children. India had a 20% representation here from that perspective. And what they were looking out in that regards is ideal situations. These were children who were not twins, who were not SGA. Mothers had exclusive breastfeeding, there was no maternal smoking, and nutrition was normal. So they wanted to see how the children grew across the world. And what they found was that if everything was ideal, the growth of children was similar across the globe. And therefore, they developed this 24-month data, which was longitudinal. So only the first 2 years is longitudinal. Then till around 6 years, they have got a data which is mainly cross-sectional. So again, standard part is only limited to the initial phase. And what we are seeing here is that the WHO chart, which we use till 5 years, the data which is even being used in the IAP one, will have data which is cross-sectional also in that perspective. And when you use this WHO data in real life Indian practice, you will realize that those cutoffs tend to overestimate short stature because their cutoffs are higher. So children who are identified as short in that cutoff may not really have a likelihood of short stature when they correct us for our own population. So that is the problem of WHO growth chart. They overestimate growth failure. And on the other hand, because their obesity cutoffs are high, they will underestimate obesity. So that's why there is a need for regional graphs in that regards. And that led to the development of the IAP 2015 growth chart, which was basically looking into 0 to 5 for WHO, 5 to 18 years based upon 9 Indian studies of a large cohort of 33,000 subjects. And they used the typical thing that they talked about, exclusion of outliers, and they developed this chart. Now, how do we know that these charts are representative for the Indian children? Our group has done 2 big studies to look at both obesity as well as short stature. And what we really find out was that if we are using WHO growth charts in Indian children, we are over-identifying short stature. But most of these children who are identified as short do not have a pathological cause. While somebody who is identified from the IAP chart will have a likelihood of pathology. So we are meaningfully identifying short stature. If you're looking at the IAP charts, if you use WHO or CDC, you are unnecessarily labeling people who are not even short. So this was something which really said that this is good. We also proved in community studies that these charts are much more representative from the other international charts in that regards. There are also disease-specific charts which are available for conditions like Turner syndromes. You plot on them, and when they're deviating from those charts, it means that besides the growth failure in Turner syndrome, they also have other possible causes which may be affecting them, like celiac disease, like hypothyroidism, or maybe really concomitant GHD. Down syndrome and achondroplasia also, there are specific charts which are available. Now, very importantly, I talked in the very beginning that we don't even need to have a picture. Now, the phase is actually of video. So if you look at Facebook maybe 10 years ago, it was all about pictures. Now it has become running videos from that regard. So we are now going to shift not from just a single assessment of growth, which still is relevant, but what we want is a growth velocity, which is going out from that perspective. Now, very importantly, whenever we talk about short stature, we talk about values less than third centile, and I'll talk about that a bit later. But from growth velocity perspective, the normal is 25th percentile. So we're talking about one standard deviation score as a measure in that regards. Now, there are now wonderful Indian growth height velocity percentile charts which have been developed by Dr. Vaman Khadilkar, who has done the maximum work in terms of development of growth references in India. And these charts are available easily, and they will tell you the various aspects. So remember to look at the 25th percentile as the mark from that regards. So growth velocity, basically, if you look at the chart, the other thing to remember is that look at the age-specific growth velocity. So in general, children grow fast till around 4 years and they become slow. Any time if they are growing less than 4 centimeters per year, that is a cause of concern. I think that's a big message I like to give from that regards. Remember, there are errors in growth velocity assessment, so you should have a minimum data of 1 year. There would be higher variation, and therefore, if we do not have reliable data, less than 1 year is of course not going to help out in that regards. Very interesting thing now is that, as I remember, I told you that during pubertal age group, it is the pubertal status which is more important as compared to your actual age. So they are now SMR corrected data which is available, in which these charts are available, and you can plot according to their pubertal status, and that gives a good information. Now we have talked about how growth charts are formed. How do we decide which chart to use? Now the question is, how do we really define short stature? Now, when we talk about conditions like diabetes, we are very, very clear that if your glucose levels are above a particular level, which on long term can be harmful. So if your fasting is above 126, if your 2-hour value is about 200, your A1C is about 6.5, long-term complications will be more. So you know very clearly that this is how you define. But how do you define short stature? And that's a big problem. So mostly we are talking about how far away that particular individual is as compared to the median or the mid part of that population. And this is done either by the basis of ranking. So you arrange the children in the order of their height and see which rank they file, which is basically the percentile, and also how much deviation compared to the mean, which is the standard deviation score. Now, all of you know about percentiles. Definitely, it's part of our everyday life, and a lot of people use percentiles significantly. I would say that now the time has come to move away from percentile to standard deviation score, because percentile is just giving you a rough ballpark figure. Standard deviation score is telling you the severity of deviation which is happening from the mean. And there are multiple tools through which you can get these standard deviation scores available. It's basically observed minus expected upon the standard deviation. Now, just to give you an idea, so when we talk about percentile, we're talking about ranking, deviation from normal. SBS is a better marker in that regards. Now, roughly, of course, 0 percentile is 0 SDS, minus 1 is around 15th percentile, minus 2 is 2.3, 1 percentile, which is 1 in 100, is minus 2.25, and minus 3 standard deviation is 0.1 percentile. So what you need to remember is that when you say minus 2 to minus 3 standard deviation score, it's not just a linear progression. It is more like the decibel progression, or more like the Richter scale progression, in that Richter scale of 5 to 6 will be much more severe. Similarly, what I'm trying to say is that when somebody is at -2, there is 1 in 40 chance that this could be because of a normal process. While if somebody is less than -3, it means there is a 1 in 1,000 chance of being normal. So the odds of having -3 standard deviation score is 25 times lower as compared to -2. So as the severity of the SDS goes up, the chances of pathology, the chances of a treatable cause become much more important, and therefore stick to standard deviation score. If you say less than third centile, it may have no meaning. It could be -2 SDS, or it can even be -5 SDS. So standard deviation score is a much better picture from that regard. Now, most important part of the talk is now how to use a chart. So of course, you have to select an appropriate chart, which for this day and age is of course the IAP 2015 chart. Calculate the exact age, plot in the chart appropriately. So do not pick a big one, put a small dot so that you will be able to identify and track that easily from that regards. Now, when you look at a growth chart, look at three crucial things. What is the absolute status of the child? How is the child compared to the population? And this you can do it using percentile, which we discussed. So less than third centile is something which people use most commonly, or the height standard deviation score. And I'll talk about -2 and -3 as the two cardinal numbers you need to remember. We'll talk parental expectations, and we have talked about how you do it: a mid-parental height plus 6.5 for boys, minus 6.5 for girls, and look at target height and target height SDS. What we have come out is a term called corrected height standard deviation score, which is the difference between height standard deviation score to the target height standard deviation score. And if the child's corrected height standard deviation score is more than -1.5, and I'm saying more than -1.5, I'm saying -1.4, -1.3, it means that this child is not short for the family. So this is a familial short stature. And finally, look at whether it's the weight or the height which is more affected. And we already said that if you have a short and lean child, this is suggestive of a case of nutritional cause. Short and plump is suggestive of an endocrine cause from that regards. And if you ask me a single parameter to look at, which will give you a prediction, it is the BMI standard deviation score. If the BMI standard deviation score is less than -1, that is indicative of a nutritional cause of growth failure. So three questions to look at: whether the child is short for the population, short for the family, and whether short for the weight. These are the three questions which will give you the answer in most cases. So I'll use this example to highlight. A 12-year-old girl, we can see the height is 132, weight is 28. So if I plotted, the child is short for the population. The next question is whether she is short for the family or not. The familial is like 151 centimeters. I draw a line plus minus 6 centimeters and draw a parallel. So what we are seeing is that this child now, once we have corrected for the family, is not short for the family. And if you look at the height age, which is the age at which the current height becomes the 50th centile, you draw a line from this point to the 50th centile, draw a perpendicular. And similarly, weightage, both of them are 9 years. So what we're trying to say here is that this child is 3 years behind both for height as well as weight. So there is no specific nutritional component, so to speak. It is a generalized growth failure, but this child is not short for the family. So this is a case of familial short stature. If the bone age is normal, if puberty is normal, nothing needs to be done in that perspective and regard, then we can follow up from that perspective. The big question is, how do you define short stature? So what we used was a very interesting thing. We decided as to what was the chance of a pathological cause as far as height is concerned. So if a child is above -2, and if I say -2 SDS above means -1.5, -1, the chance of pathology is only 2.5%. But as the SDS goes to -2 to -3, the chance becomes 42%. And if it is less than -3, it becomes 80%. So anybody who is less than -3 is nearly pathological. You cannot miss them. So this traffic light approach will help you out. If somebody is more than -2, it is green. -2 to -3 is orange. Wait and watch. If it is less than -3, it is a red sign, and definitely you will need immediate evaluation from that regards. To put that in perspective for growth chart, if you have a child like this who is way off the chart, definitely requires evaluation, height below first percentile. Somebody is here and is deviating from the chart, short and not growing. Height is first to third centile and growth velocity is less than 25th percentile, needs evaluation. And finally, if somebody was normal now, but has not been growing at all for the last 2 years, crossing 2 or more percentile lines between the age of 2 years and puberty is clearly suggestive of short stature. So somebody who is very short, short and not growing at all, needs evaluation. So we talked a lot about growth. Very important part to remember now is about adiposity, and obesity is also becoming common. So the markers we use is body mass index, which is basically weight upon height square in meter. Waist circumference is a marker of regional adiposity, skin fold thickness for the amount of subcutaneous fat you have. And of course, we have got standard measures like DEXA, bioimpedance, and plethysmograph, which can be used in clinical perspective. But most important parameter which we often use is body mass index. So when we talk about how to decide about obesity, less than 5 years, the parameter to look at is weight for height, 2 to 5 years, and weight for length below 2 years. And in that regards, if the parameter is more than 3 standard deviation score from the WHO criteria, there is obesity. More than 2 standard deviation score is overweight. This is the graph which is available. After 5 years, we have to go for BMI, and how do we define BMI is an important question in that regards. Conventional definition of obesity, like the CDC criteria, was just the population based. So they just said that if you are above 85th percentile, you are overweight, 95th percentile is obese. What it means is that always 5% will be obese, 15% will be overweight. If the whole population becomes obese, what do you do in terms of that? So what IOTF, the International Obesity Task Force, did was very interesting. They backtracked from the adult cutoffs. Now, adult cutoffs were 30 and 25 for the international population, and they were based upon mortality. So if you look at the adult mortality compared to BMI, there is a J-shaped relationship between BMI and mortality. If you are below the normal weight category, there is more mortality. If you go beyond 25, the mortality increases very significantly. And beyond 30, it rose up really fast. And that's how you got the 25 and 30 cutoffs. So what they did was that they said that, okay, at adult age, what is the standard deviation score for this 30 and 25? And I'll backtrack this to every age to identify in children. And they developed this backtracking model. So this was something which was quite useful because this was linking the obesity to complications rather than just linking it to a statistical definition. So the same thing was used by IAP, and they talked about using the Indian cutoffs. Now, Indian for the same level of BMI have more fat. So there are revised Asian cutoffs of 27 and 23, which are recommended for defining overweight and obesity in adults. And the IAP criteria uses again the 27 and 23, backtracking from there. So this is the most common error whenever we ask from pediatric graduates about the obesity definition. They often talk about percentile cutoffs. They often talk about adult cutoffs. What they need to emphasize is that it is a backtracking from the adult obesity, which is 27, and adult overweight, which is 23, which is criteria which is used from that perspective. Now, BMI, of course, can have limitations because it's just looking at weight. It's not looking at fat. If somebody is more muscular, they may still have the more BMI. Puberty will have an impact, more puberty, more BMI. So if somebody is having a late puberty, you may have differences in terms of BMI estimation. And of course, Indians for the same level of BMI, I already said, have a higher amount of body fat. So these are the limitations as far as BMI is concerned. So we have covered a lot with regards to the growth chart. Just a couple of important words about pubertal assessment. Now, pubertal assessment should be done in every child, and we often don't do that, and we miss out in terms of growth evaluation. If you don't remember the entire pubertal progression, remember two sites: breast stage 2, which is papilla elevation, because here the development is happening. Always remember that the growth spurt is going to happen from here, and from here a girl is going to gain around 20 centimeters. Very importantly, a lot of obese girls come to us who are coming to us with complaints of breast enlargement, but that is actually not breast development, that is lipomastia. So all you have to do is to approximate your thumb and finger. And if you are able to find resistance, that is suggestive of a breast tissue. If there is no resistance, that is lipomastia. Now, the second stage to remember is the secondary mount, which is breast stage 4, which means that now the growth is only around 10 centimeters, which is left. After menarche, we have 5 to 8 centimeters. So if you just look at a girl and their breast stage, you will know how much they're going to land up. So if somebody is 135 centimeters at breast stage 2, she's going to land up around 155. Breast stage 4 is going to land up at around 145, and at menarche only 140. So this is a very, very important aspect to evaluate and assess from that perspective. What about boys? Look for testicular volume, and we have got orchidometers which can be ordered from the ISPE website. This is a very good tool to identify pubertal assessment. Levels more than 4 ml will indicate that puberty has started, and more than 10 ml would mean that there is a rapid progression. So if you have a child who is short at 4 ml, you can wait. 10 ml, wait for 6 months. 15 ml, do not wait. There is not much time which is left from that regards. Now, this child, again, I'll showcase a few cases. 13-year-old boy, height is 135 centimeters, weight is 30 kgs. And what we can see, this is the growth chart. Now, what we see in this case is that this child is having short stature. He's short for the population. He is also short for the family, and bone age and height age and weight age is already 9.5 years of age. Now, this was the bone age which was done. And based on the bone age, which was reported as 14 years, this child was recommended for growth hormone therapy. Now, this is something which we reassessed and found that the bone age was only 10.5 years of age. So this really changed the whole management. So after growth chart, after puberty, the next most important thing to look at in a child's growth is the bone age. And these three things will tell you whether it is physiological or pathological. So bone age of 14 means growth hormone treatment. Bone age of 10.5 years means just follow up. So what you need to remember is that when you talk about the skeletal maturation, it happens from proximal to distal, while fusion happens from distal to proximal. And therefore, at different times of life, you need to have different areas to look at. Girls have higher estrogen as compared to boys, so they are more advanced in terms of growth. The single most important thing that you have to look at in terms of the bone age maturation is the comparison of the epiphysis to the metaphysis. If your epiphysis is much smaller than the metaphysis, it is somewhere around 4 years, it becomes equal at around 8 years, it caps and becomes bigger at 12 years. So if you want to look at a single bone, single practical aspect, look at the middle phalanx, middle finger, and 95% of variation, this is from our own validation data, will tell you that this is the most important part, and compare the metaphysis and epiphysis. A lot of people say carpals are very important. They are not very important because there are a lot of variations in terms of carpal maturation. You don't need to remember all that. Just remember that till 1 year, you will have capitate and hamate. And then after that, there can be a huge variation. So carpals are very helpful only in the initial 2 years. And one carpal which may be of help is the pisiform bone, which appears around 10 to 11 years of age. Phalanges are very, very important because, as I said, the maturation happens from proximal to distal. So early age of life, this phalangeal appearance will give us a clue. Most important is that variation of epiphysis to metaphysis. And what we are seeing is that it is smaller till around 8 years of age, equal from 8 to 12, becomes bigger beyond 12 years of age. And this is what you should look at in an X-ray. Long bone epiphysis, of course, become important. Radius is more important than ulna. And ulna basically appears around 5 years of age. Then this head of ulna becomes prominent, and then finally fusion happens. So looking at the bone, if you predominantly look at 3 different regions, you're looking at the difference between metaphysis and epiphysis. You're looking at the long bones and looking at carpal. If you combine all of them, you will get a good idea. Now, where should you get the bone age X-ray done? For neonate, which we do only for congenital hypothyroidism, look at the knee. Otherwise, every child will be non-dominant hand, and you should be an AP view X-ray. Do not go for the other views. And very importantly, for fusion from a forensic perspective with elbow, but for pediatric endocrinology and growth, it's mainly the left hand and wrist. Always have the full hand because the distal part is very, very important. Always the finger should be spread and exposure should be proper from that regards. Now, very importantly, if you look at from the options which are available, there are various tools, gold standards, which are available like Rulage File Atlas, in which you just have comparison of the hand to a particular X-ray. Now, the problem here is that sometimes somebody's epiphysis is behaving differently, carpal is behaving differently, and long bones are behaving differently. So how do you place? It's not a simple matching from that perspective. So there could be a variation which can be done. It is, of course, a much older study, which is done from the US children. So Tanner Whitehouse came up with another idea of segmenting the bone age assessment. So they divided it into 20 segments, and based upon those 20 segments, you give score to each side and then give a good result. This is a much more validated, better process, considered gold standard, but this requires a lot of time. So clinical practice, you may not be able to do it from a non-expert perspective. And bone expert, finally, there are now automated tools. You get the X-ray, DICOM image, they will immediately give you the various results from that regards. Now, what I'm trying to say is that these are not easy to identify. The radiologists are not very proactive in terms of bone age assessment. So all of you should have some idea as to how to do bone age assessment. Before 2 years of age, how many carpals have appeared, how many phalanges have appeared is good enough. But the crucial phase from 2 to 12 years or 2 to 14 years where you're worried about is single most thing is to look at is the middle finger, middle phalanx, epiphysis to metaphysis, whether it is small, equal, bigger, or capping. 4 years, 8 years, 10 years, and 12 years. And you can really identify that. And then long bone can be used for fusion perspective. So infancy, you look at the carpal. For toddlers, you look at the number of bones. Pre-pubertal, you look at the size of epiphysis, which is becoming bigger. Mid-puberty, it is becoming equal. And late puberty, it is actually fusing. So 7-year-old boy with short stature, I'll segmentize it into 3 parts. Epiphysis is very small. Carpals, only 3 carpals appear, only radius is there. So this child's bone age is very delayed. What do you think is the bone age? This is clearly quite delayed. And as I said, if you have an epiphysis which is much smaller, we are talking about a figure of somewhere around 3.5 to 4 years. So this is very delayed, likely a GHD scenario. A 13-year-old boy with short stature and delayed puberty, again, if you look at the epiphysis, it is just equal or slightly lower. Many carpals have appeared, pisiform has just appeared, and you have got good radius, but the ulna, the head is not very prominent. So what you're looking at is bone age of approximately 11 years from that regards. 7-year-old girl with early puberty. So often in early puberty, bone age becomes advanced. So what you're seeing, epiphysis is quite big here. Carpals are very significantly present, and long bones also you see they are prominent. So the bone age is 11.5 years. So this girl at 7 years, because of early puberty, has got a bone age of approximately 11.5 years. And that clearly means that we need to do evaluation, assessment, and management for early puberty in that regards. Finally, we can do an adult height prediction using what your current height and your current bone age is, and you can make a prediction using the bone age. You can also incorporate the parental height, which will give you a clue on that regards. So there are various ways in which prediction is done for adult height, which tends to be over prediction, but this is something which will give you an idea as to where the child will land up. One of the classical methods is the Bailey-Pinau method, which tells you how much proportion of the growth has happened in a child. So you just need to remember that this is a way of predicting height. If you get a theoretical question, you can say, okay, you have Bailey-Pinau method in which you know the age, bone age, how much height is there, and you will get the idea. So 7-year-old girl with early puberty, the example I gave, height is 125, bone age is 10.3, which means 84% growth has happened, which basically means the expected predicted adult height is 148.6. These are the methods which are there. So in bone age, what you need to identify from a practical perspective is to have a rough idea. Plus minus 2 years is okay. From my perspective, if you can do it at a pediatric trainee level, you also need to understand the various methods like GP method, like Tanner Whitehouse, and the Bailey-Pinau table for prediction from that regards. What we have done to simplify things, particularly for pediatricians and trainees, to develop a simplified measure of bone age in which only 5 sites, which are the most important, which have to be looked at. This is part of our MediClasses tool. Once these sites are selected and we compare these X-rays and look at which is closest to that, all you have to do is to do that and you'll get a precise estimation with a great confidence from that perspective. We've also developed a AI-based bone age interpretation, which just have to load the X-ray and you will get up the bone age from that perspective with a very high sense of accuracy. So now we are moving in terms of further easy automated bone age assessment, but we need to have a basic idea as to how to assess the bone age. So I've talked a lot about whether it is short stature, physiological or pathological, using bone age, growth chart, and puberty. Now, what about the other questions? So as I said, first question, is it short for the population? Second, short for the family. So you look at the corrected height standard deviation score of more than minus 1.5. Then third important question is constitutional delay of puberty and growth. Now, bone age is important to tell you not only about how much growth is left, it also tells you whether this could be a CDGP. So in children who have growth hormone deficiency, the bone age will be much more affected. While in those who have CDGP, the bone age will be commensurate to height age. So if the child is short for the population, short for the family, but not short for the bone age, that is CDGP. So 80% of your cases are done out there. Look at the clinical picture, dysmorphism, disproportion, which gives you a picture. What about history? Ask for gastrointestinal symptoms. Consider things like pallor, pica, wheat aversion, and rice preference. That could be celiac disease. Inflammatory bowel disease after 10 years becomes important. So there could be more abdominal pain, cramps. You may have pus in the stool, and those things become important. Hearing abnormality with a child with short stature, think of Turner syndrome, very importantly, and pseudohypoparathyroidism. Rickets with short stature would suggest celiac, renal failure, and nutritional, of course, as a cause. Ask for polyuria for RDA and renal failure. Look for respiratory symptoms. So head-to-toe examination becomes absolutely important, and neurological features also become important. Look for dysmorphism, disproportion. Micropenis, as we said, may be an indicator of hypopituitarism. Anemia, pallor will be suggestive of celiac and renal failure. Clubbing is particularly important from celiac and respiratory infections. And brachymetacarpia, which is a short fourth metacarpal, which means a problem in the SHOX gene. Turner syndrome, pseudohypoparathyroidism become important. So a comprehensive head-to-toe examination becomes important. This will be relevant from a clinical case perspective, but I've seen questions in which this examination has been asked, so you can make a table highlighting these parts from that regards. Now, a few charts which you need to draw. This is a typical pattern of constitutional delay of puberty. The child is fine till around 8 years of age. Following with, you see a faltering. They keep on, however, growing for a longer period and land up normally. So if you see a chart like this, child is short for the family, short for the population, but not short for the bone age. So there's a family history in the father or the mother with delayed onset of shaving or delayed onset of menarche. Very importantly, they do not have any pubic hair development. So if they have a pubic hair development, it is not CDGP. All you have to do is observation here, or maybe give a short course of sex steroids, which will improve that. If you see this pattern, child is short for the population, but not short for the family, continues to be short, bone age is normal. So finally we'll land up short. This is familial short stature. So there will be a family history of short stature, normal puberty, normal bone age. We may consider growth hormone. This could be that idiopathic short stature for growth hormone where it is considered. The third important thing is nutritional versus endocrine. So if you have a chart like this, in which the major impact is in terms of weight, this is short and lean, this is nutritional. If you have a major impact on height, which is short and plump, this is endocrine. So this becomes important. So finally, to summarize the workup, look for growth chart, puberty and bone age, facies, proportion, birth weight. Consider karyotype in girls who have got normal workup. Consider genetics, look for skeletal survey, and look for the basic workup, including ALT, creatinine, and TTG. Blood gas becomes important, and fecal calprotectin becomes important from that regards. From endocrine perspective, thyroid profile becomes important, and growth hormone stimulation is important also from that regards. So everybody, we should get a CBC, ALT, and creatinine. TTG, even if there is nutritional or not pattern, thyroid, even if the pattern is different, we should get it done in everybody. This is a basic fundamental investigation. And then if needed, We can do karyotype in girls in which all other workup is normal. RTA is important, but if you have RTA usually below 3 years, they may not have any other symptom, but beyond 3 years, they will have other features like rickets, like fracture, like polyuria, like hypokalemic paralysis. So less than 3 years, everybody should have a blood gas. Everybody above 10 years, particularly with nutritional pattern, should have a calprotectin, which is to be done. And growth hormone estimation should be done only after everything has been found to be normal in that regards. A couple of words about growth hormone axis evaluation. Not going to go into too much detail. What you need to remember is that growth hormone is a pulsatile hormone. So if you want to really do some assessment, do not do a basal growth hormone. Do a growth hormone stimulation test, and we've got pharmacological agents like insulin, glucagon, and clonidine, which can be used, which are the gold standard. They need to be admitted, interpreted appropriately. Remember that they should have a normal thyroid and cortisol axis before this is done. And in children who are prepubertal and borderline short, we need to do a sex hormone priming. So I already said that you need to have a normal gonadal, thyroid, and cortisol axis before you really do a proper estimation. So this requires a comprehensive pre-test probability and evaluation in that regards. IGF-1 and IGF-BP are screening tests, but they depend on the nutrition and liver function. So if you want to do these tests, less than 5 years of age, do both IGF-1 and IGF-BP3. Beyond 5 years, IGF-1 alone may be good enough. But remember, if the levels are low, you still need to do a growth hormone stimulation test. A word about celiac disease, which is very, very common. Remember that TTG is a good screening test, but unless the levels are more than 10 times normal, you need to do a biopsy. About 10 times, you can do another antibody, which is endomysial antibody. If it is positive, that will be celiac disease. If it is negative, you have to do biopsy. If TTG is between 1 to 10 times, you should do a biopsy. And if it is negative, when you have a high index of suspicion, you should look at IgA levels. If IgA is low, that is 10% of all your celiac disease, then you have a false negative TTG, you do a GI referral in that regards. So combine TTG with biopsy only with EMA if it is very, very high. If the unit is 20, it's more than 200, you can go from that regards. So to summarize whatever I have talked about, in the first question is to say whether the child is short or not, which is height standard deviation score, more than -2, no workup is required. -2 to -3, the next question is the child short for the family? Look for corrected height SDS. Corrected height SDS above -1.5, no workup is required. This is familial. Then the next question is short for the bone age. So short for the population, short for the family, short for the bone age. If the child is short for the bone age, you need to work up. Otherwise, this is CDGP. So this is 90% of your cases I'm talking about on the left side already sorted out. Otherwise, you do screening, and we talked about CBC, ALG, creatinine, electrolytes, TTG, thyroid, and blood gas. If they are abnormal, you get your diagnosis. Otherwise, you follow for at least 6 to 12 months. However, if the child is already below -3 standard deviation score, you have to start thinking. You look at syndromic features, then you look at IgA in somebody with nutritional pattern, karyotype. If all that is normal, then you do a growth hormone stimulation test. So growth hormone testing should be done at the end. Otherwise, you will be confused from that regard. So this is the approach. And this approach is basically customized for resource poor setting. Then we have shown that this substantially reduces the burden of investigation in terms of the cost compared to the Western guidelines which are there. And when we validated this in our group of around a large set of patients, what we found was that there was a 99% concordance. What people have to do is to just put their information about their height, their weight, their parental height, and the bone age, and this will give you a clear clue as to the various parameters that are there. It would also inform you about the likely diagnosis and the workup which has to be done in that regard. So this is what's available as part of our evaluation. It will give us a lot of tools and the diagnosis from that perspective. So just to highlight a few cases, this is the case we discussed already. This is a child who is short for the population, but not short for the family. So this is a classical case of familial short stature. So that becomes important to identify. And if you look at the growth interpreter, you will get that diagnosis. And this gives you a good idea. Another case, 12-year-old girl, height is 120, weight is 15. The child had a hemoglobin of 10.2, TSH and TTG was normal. And what we look at the various parameters. What we're seeing here is that this child actually had a nutritional pattern growth failure and was mislabeled as a case of GHD. So always look at the growth chart before you order these specific tests from that regard. So this is a 13-year-old boy. We see this child is short. And what we are seeing here is that this child is short, not only for the population, but also for the family. But this child is not short for the bone age. So this is a very, very classical example of what we call is a scenario of CDGP. What you need to do in this regards is just to follow up. Unfortunately, if you do a growth hormone stimulation test without priming in this scenario, you will get a wrong result. So what was done in this case was basal growth hormone was low, and without priming growth hormone test was found to have a level which was low, labeled as GHD. But when the child came to us, we did a test after priming, which is giving testosterone and repeating after a week. It was normal. So this is a classical case of a normal constitutional delay of puberty and growth. So if you have a child who is just below the third centile, is within the family, is taller than them, the bone age is delayed, puberty is delayed, do not worry. This child is going to go up and improve over time. What about this child? What we see here is that the major impact is at the level of weight rather than height. But on workup, what they found was TTG was negative, IGF-1 was low, and basal growth hormone was low. So they were diagnosed as GHD. Now, this growth chart clearly tells us that this is not GHD, this is nutritional cause. If you are malnourished, your IGF-1 will be low. So that's why when you look at growth hormone stimulation regime, remember IGF-1 is not a good marker, it is age dependent. It is nutrition dependent, and always do a growth hormone stimulation test properly before making a diagnosis. So what we did in this case here was that we found that this child had a negative IgA. If I go back to this case, had a IgA deficiency, and this was actually a nutritional cause, not an endocrine cause. If we had looked at the growth chart, we would have made the correct diagnosis. A very interesting scenario again, and what we see here is that this child, again, the height is more effective. So if you look at this chart, you say this was endocrine pattern short stature. The workup showed a borderline TTG. Now, what was done here that this was labeled as celiac without doing a biopsy, and there was no response to gluten-free diet. So this again is not a case of celiac disease. This is clearly looking like a nutritional pattern. As I said, if you have a predominant impact in terms of the height compared to the weight, this is endocrine. So again, think before you order test. A scenario which I always want to discuss is a 15-month-old girl who was large to begin with and gradually was going off the chart. At that point of time, it was thought that there needs to be a workup. The pediatrician did a workup and they found there was mild acidosis labeled as RTA. Now, if you look at this chart carefully, the parental expectation on the right side is quite low. Remember, size at birth is determined by environment, size at final height is determined by genetics, and the switch happens at 2 years. So this child was actually an infant of diabetic mother, was destined to be short, was tall because of diabetes, and this tapering that you are seeing is a normal catch down growth. Do not do unnecessary workup if there is a target height appropriate catch up or catch down in the first 2 years of life. When I say a change of percentile lines between 2 years and puberty, that is different. Less than 2 years, you may have panel, which is happening from that perspective. So we have discussed a lot about evaluation because there were a few questions on growth hormone therapy. I'll just touch base very briefly. Growth hormone, as we know, is a large polypeptide. It is a non-glycosylated one and a agent which is the primary regulator of growth. There are other forms of growth hormone which are there as well. The growth hormone levels are high immediately after birth. They remain high throughout childhood, peak around puberty. So in puberty, you will need to maybe give a higher dose of growth hormone. They are also important for skeletal growth. And after that, there is a somatopause in that the growth hormone levels become lower in older individuals. So if you talk about growth related treatment, we're talking about treatment around fusion of epiphysis. The condition in which growth hormone therapy is approved is growth hormone deficiency, Turner syndrome, SGA, chronic kidney disease, Prader-Willi syndrome, and idiopathic short stature. Now remember, other than GHD, you do not need to do a growth hormone stimulation test. You can give the therapy without a growth hormone stimulation. There are various other scenarios in which it's been experimental, like skeletal dysplasia, thyroid toxicity, hypophosphatemic rickets, and other syndromic associations. But the main ones in which we're using is growth hormone deficiency, Turner syndrome, and SGA. Now, for growth hormone deficiency, we need to remember that you need to make the correct diagnosis. The child needs to be short. Growth hormone stimulation should show a level which is low, and IGF-1 level may alone be considered if there are other features like malformation or insult which is there. We discussed that we use 25 microgram per kg per day in childhood, a slightly higher dose during puberty, and later on, if you want to transition, use a lower dose. But most Indian scenarios, we're not using in adult GHD. In severe GHD, we start off with lower doses. In milder, we might have to start with a higher dose. In puberty, the dose requirement may go up. We expect that in the first year, they will grow around 10 to 12 centimeters. In the second year, around 8 to 10 centimeters. And the bone age has to be monitored very carefully. And IGF-1 level is the marker of safety. So if your IGF-1 is very high, you're giving a high dose of growth hormone from that perspective. Look for edema, which happens because of protein retention, happens in 1 in 300. If somebody complains of headache, the visual difficulty, it could be a benign intracranial hypertension, again, an effect of increased growth. You may unmask hypothyroidism if growth hormone therapy has been given to monitor FT4. Very importantly, if a child has a very rapid growth, the capital epiphysis, femoral epiphysis may slip. They may come to you with bone pain. They may come to you with difficulty in walking, knee pain or leg pain. That is relevant. Very rarely glucose intolerance or tumorigenesis. This is not significant. So main effects which we see in clinical practice are mild edema and benign intracranial hypertension, which improves over time. Thyroid functions have to be monitored very, very carefully. We now have long-acting growth hormone, which have been developed by various measures. In India, we have got somatogron, which is an agent which has basically been developed by modifications in terms of the site of addition of the HCG moiety to make it more longer. So growth hormone therapy is clearly indicated in growth hormone deficiency with huge benefits, which are there. It is also indicated in other scenarios like Turner syndrome. So Turner syndrome girls are 20 centimeters short. So if you have a girl who is short or a high likelihood of short stature, consider treatment. The dose here is double as compared to GHD, and you usually start around 4 to 5 years of age, and that is the best time to start off. From that perspective, you expect a gain of around 1 centimeter per treatment year with growth hormone therapy. Because of the higher dose, you can expect more adverse effects, so we need to be more cautious in that regard. There is no need for growth hormone stimulation test here. Small for gestational age, very important indication, 90% of SGA catch up by 2 years. If they have not caught up, that would be a scenario where you would need to consider growth hormone therapy. So if somebody is short at 2 to 4 years of age, and now in India, we talk about usually 4 years, evaluate for all systemic diseases, assess for nutrition and contraindications like chromosomal breakage syndrome. If they are not there, we may give them growth hormone at a slightly 1.5 times the dose. Expect a gain of around 1.1 to 1.5 centimeter per treatment year from that regards. So this table summarizes, which you can use if you have to answer that about the various indications. I put the top 3, GHD, Turner, and SGA. CKD, Prader-Willi, and idiopathic short stature are more less used in that regards. In Prader-Willi, this is more for body composition effect rather than the overall growth from that perspective. Idiopathic short stature is a very controversial indication, so we give it more like a trial rather than a long-term therapy. So this table can be quite useful. So I have covered what most part is that. I'll quickly go through a few questions which Professor Nagbhushan had shared to me. And most questions were pretty much about what really is short stature, what are the different causes, how to approach. And then there were these clinical scenarios of different age and height, which is there. So I think this main thing would be what is short stature, what are the various causes, and how do we evaluate. We have covered this, so we can use this graph as an idea about 3 criteria: somebody who is very short, short and not growing, and not crossing at all, not growing at all, we can define these three. So we can say a cross-sectional or a longitudinal growth failure as a criteria. Use both SDS, less than -2 standard deviation score, and height below third percentile, and a combination of height and growth velocity. I think that will be good for the overall process in terms of what is short stature. Second part is cause. If we can use this diagram, you can clearly use this to identify physiological versus pathological and then elaborate from there. This also summarizes the various investigations. You can use it in an investigational perspective. This approach, which is indigenous and looking into the India specific thing, whether the child is short for the population, short for the family, short for the bone age, and then you can use this growth chart to really use algorithm to identify that from that perspective. We also talk about growth hormone therapy. So again, the various indications in the table that I talked about can be used to identify that. Now, again, this is the thing about history and physical examination and role of investigations. Again, this is important. So we talk about the various historical points I talked about, starting from birth weight to GI symptoms, to deafness, to rickets. All those scenarios become important. Examination for dysmorphism, body proportion, hyperparathyroidism, all those parameters become important. And investigation and growth and approach we already talked about. Growth chart, we have talked a lot. So you can use these things about why growth chart are relevant. What about IAP growth chart, how they have been developed, these specific growth charts, what to look at growth charts. So you can classify the three parts, compared to the population, compared to the family, compared to the weight. That becomes important, and how to use, we can then elaborate from that perspective, which I've discussed in detail. We can put these two examples of CDGP, which is faltering and then delayed bone age having a normal final height, and familial short stature short throughout as an examples to highlight in that regards. Now they have given various cases, so you need to have an idea as to which age, what should be the normal height. So if they say 14 years, it's 120. You say we expect the height to be there. 120, they expect it to be below -3 standard deviation score. And then nutritional versus endocrine is what you need to put out. A growth velocity curve again, so this becomes important. So this gives you a longitudinal picture, and you're looking at 25th percentile as a cutoff in that regards. Now there are a lot of questions on bone age, so you need to tell when should bone age be done. So every short child, everybody with precautions or delayed puberty, want to know about height prediction, do a bone age. Now you can use this as a simplistic tool to use bone age. Talk about there are three methods, Tanner, Whitehouse, Grulich, Pyle, and automated methods. And bone age gives you an idea about that. Mid-parental height, again, we have used this in the slide, the difference of 13 centimeters. How do you subtract and add for boys and girls? And the range, how do you use it from that perspective, and what discrepancy could be there? So I think you will be able to write on that. Again, a number of questions on BMI. So clearly we talk about how do we assess weight for length or height less than 5 years and BMI above 5 years. The backtracking concept is very, very important. So if you explain 27 and 23, these are adult obese and overweight criteria. And from there, you see what percentile or what SDS equates to that in adult, and you backtrack for different scenarios. That is important from that regard. And you can mention about limitations in muscularity, puberty, and ethnic effects, which can be significant. So I think I've tried to cover most of these questions. There are many books which are available from our side. Pediatric endocrinology protocols in particular has got a lot of algorithms. So all the algorithms which are there already there. And if you want more deeper understanding their basic and advanced endocrinology, and you can go and have a look at our website as well as YouTube, wherein all these videos will be available and you can assess from that. So I think we have been able to cover off a lot of these topics, and this was of course a long one, but I hope that we have been able to address the issues, and we will be happy to take any further questions from there. Thank you.
Audience, any questions? I think, sir, we don't have any questions as of now. Sir, one question has been asked now. Please explain how to use growth chart.
Okay, so I think we explained it in much more detail in the class. So basically, first of all, you have to select the right chart. So that is what you're looking at is IAP 2015 chart. You, of course, measure it properly, look at the age, height, and weight. You plot the height and weight in the appropriate scenario. You plot the parental height on the right extreme corner, add 6 centimeters above and below, and draw a line from that perspective. And then from that regards, what you need to do is that answer three questions. If the child is basically having a height which is shorter for the population or not, if not, the child is not short. Second, if he comes in the range of the parental height, he has familiar short stature. And then you compare it to the bone age and see if the child is short for the bone age. That will be significant. Otherwise, this becomes CDGP. The other important thing is to look at the height age and weight age. You draw a line from the point to the 50th centile, draw a perpendicular to get height age and weight age, and you will identify whether it is a nutritional versus endocrine. So I think if you look at the systematic approach, look at four things. Short for the population, yes, no. Short for the family, yes, no. Short for puberty/bone age, yes, no. Short for weight, yes, no. You will know 95% of your answers from the growth chart itself.
Dr. Rajendra, there is one more question.
Yeah. Sir, another question. Now, how we will decide mid-parental height in 8 years old child?
Okay, so mid-parental height is the same whether somebody is 8 years, 2 years, 4 years. It is constant for the child right from the birth. So what you do is that you take your mother's height, father's height, average it. For a boy, you add 6.5 centimeters. For a girl, you subtract 6.5 centimeters. That gives you the mid-parental height. Now, what you need to do is that to see the range as to what should be your expected range, you add 6 centimeters and you subtract 6 centimeters. That will give you the range from that regards, and that gives you a very good picture. Now, how do you interpret whether currently the child is going according to the parental height or not? We have said that you should go for corrected height standard deviation score. So you look at the height standard deviation score for the family, height standard deviation score for the child, subtract, and you will get whether it is less than minus 1.5, which means the child is short for the family, more than minus 1.5, the child is normal for the family. So calculate MPH, calculate MPH range. You can do it on the chart itself, backtracking as I showed, or you do a more sophisticated one using SDS, and you will know whether the child is short or not for the family.
Yes, sir. And the good news for the audience is that whatever the knowledge has been said, it will be available on YouTube. So I request audience, so you want to come with another questions.
Dr. Bajpai, I have a request. If you can put one of your cases again, and we will request for the audience interaction. They could answer it on the messages. That would be better, I think.
Okay. Yeah.
Any case for that matter, and then so it will. The PGs have to answer in the chat box so that we will know how much you have understood. That's the whole idea. And if there is any need to clarify, sir, will do it for us.
Sure. Okay, so I'll show this case. So hopefully you're able to see this case.
Yes, sir. Yes, sir.
So this is a 13-year-old boy. Height is 135 centimeters. Weight is 30 kgs. Father is 169. Mother is 156. So we have already done the hard work. We have plotted the child height and weight. Both have been plotted. We have also plotted the parental height. We have done the height, age, and weight age by drawing it to 50th centile. And we have put a yellow dot for the bone age. Now, my question is, what is the height, age, and weight age in this child? It's given already. So I think that will be easier. Now, do you think this child is short for the population or not? That will be the first question.
Please answer in the chat box. Dr. Rajendra will be able to share it with us.
Yeah.
Please don't hesitate, because we have sir to clarify now. Whatever doubts you have, it's better to express it and clarify.
So Dr. Sunanda has said this child is short for the population. Dr. Theres, Dr. Sanidhi, that's true. So this child is definitely short for the population. Now, is the child short for the family or not? That is the second question. If you answer these four questions, you will know exactly where this child is going. So is the child short for the family? Short for the population? Yes. And we see the family is coming around 25th percentile. If I take plus minus 6 centimeters, it will be within the range of the growth chart. So this child clearly looks to be short for the family. So this is one thing again, Dr. Suman, Dr. Abhishek, Dr. Sanidhi, everybody is saying this child is short for the family. So first 2 points, this child is gone, is passed, that he is short for the population, short for the family. The big question there is he short for the weight or not? So what do you think? Is the weight and height equally affected or the weight is more affected? So you can say equally affected, you can say yes. If not, you can say no. So they are equally affected. Dr. Suman, Dr. Sunanda, all of them have said that this is equally affected. So what we are seeing is that this child is short for the population, the child is short for the family, but not short for the weight. This means that the weight and height are similarly affected. Now the final question is the child short for the bone age or not? Bone age is the yellow dot that we have put. So if you correct this child for the bone age, that is you shift him to the bone age side, is he short or not? So clearly what you are seeing here is that the bone age, he becomes equal to around 25th, 10 to 25th percentile. So clearly in this scenario, this child is not short for the bone age. So if you ask this four question in everybody whom you are plotting the chart, saying that short for the population, yes. Short for the family, yes. Short for the weight, no. Short for the bone age, no. So this case clearly is now going towards CDGP, constitutional delay of puberty and growth. Now, what the problem was in this case was that the basic workup was normal, and then somebody thought, let's do a growth hormone testing, and they found growth hormone level to be low and growth hormone stimulation to be low. So referred to us as growth hormone deficiency. But if I go back to this child chart now, clearly this child is not having GHD. The pattern is not GHD. So what we did a growth hormone test after priming. So we gave them a testosterone injection. And after that, 1 week later, we did the test, it was normal. So this clearly excluded that this is not growth hormone deficiency. Had the referring physician not done the growth hormone test, I would not have done that also. I could have just said, okay, wait for some more time. There is no need of growth hormone evaluation, no need of 5GF1. But just to prove, we will have to do a growth hormone test after priming here, which was normal. And then we just followed up the child and we found that he continued to grow and reached a normal final height. So this was a classical case of CDGP who was misdiagnosed as growth hormone deficiency. So I hope this covers, and the key questions to ask basically are whether the child is short for the population, short for the family, short for weight, and short for bone age. 4 questions. Growth chart assessment is final from that regards.
Rajendra, any other questions in the question box, chat box? Dr. Rajendra, any questions?
Yes, sir. I think sir has excellently told regarding what is the importance of growth and starting from hormonal importance of importance of hormones in the growth and development, and apart from that, infancy, childhood, puberty model. And with the examples he has given, he has rightly pointed out how to differentiate between the nutritional causes versus the hormonal causes. I think that is very important for pediatrician or any physicians, or I can say for students, to identify at the earliest stage, because we keep on treating the child as a nutritional, and at the end of the day, later on, the child may turn out to be a hormonal. It may not be a correct from the treatment part and even from the medical legal aspect. So I think as a pediatrician, it's very important for us to rightly identify and treat the child for this identify the growth, and we should know what is the importance of the growth. So sir has rightly highlighted. I think from my side there are no questions, sir. I think the participant.
Okay. No, the only other information somebody has asked, we are doing this online teaching session. This is the first session. Every first Sunday we have it. Next session will be on approach to inborn errors of metabolism by Dr. Mahesh Kore. So every Sunday, keep your time free at this point. We will share the information. I request Dr. Bajpai to share the details of the uh, website as well as the AI monitor tool, which I heard him the other day, so that we will put it up in the group so the PGs can go and avail it, and use it to their best.
Sure.
From my personal side, from the IAP Bangalore branch PG teaching activity group, and from the IAP Bangalore branch, and from all the PGs from their hearts, we are grateful to you, sir, for sparing your valuable Sunday time to join us, to educate us, and to enlighten us. And they said a work well done, begun is half well done. So with you starting this session, our work is half done. Hopefully, others will continue. May I request Dr. Rajendra and others to take over, please? And I think we could conclude.
As we come to end of today's online enriching sessions, it's my privilege to propose vote of thanks. First and foremost, we extend our sincere gratitude to our speaker for today, Dr. Anurag Bajpai sir, for his excellent and insightful deliberation on the growth and development. His clarity in explaining the fundamental concepts combined with the practical clinical perspective he has given has really helped us in understanding the growth and development. We are thankful to our respected chairperson, president sir, and moderators for the guidance of this today's CME. I would like to express my appreciation to all participants who actively joined in today's online CME, making it a lively and meaningful academic exchange. And we would like to continue the same such online CMEs in future also. A special word of thanks to our organizing committee, technical team, and support staff for their meticulous planning and seamless execution of today's program. Finally, thank you all once again for your time, participation, and continued commitment to the academic excellence in pediatrics. With this, I formally conclude today's session. Thank you, sir.
Dr. Bajpai, you may be interested to know that it was not only PGs, there were staff members of medical colleges who heard your talk today. So it's much more beneficial than only to PGs. Thank you.
Thank you.
Thank you, Nagbhushan sir, and Raghunath sir, and Sunil Kumar sir, for your commitment in continuing this academic journey.
Thank you. Thank you. Let us call it a day.
Thank you.
एवढं सगळं चालू होतं जायची गरज नव्हती.